Hi, I'm Dr. Conrad Fischer, Professor of Medicine, Residency Program Director at Brookdale Hospital in New York, and welcome to the ZoorMed Show. And we're going to talk about how to prepare for the United States Medical Licensure exam. Now, 100 years ago, 120 years ago, people used to do 2 years of medical school, no internship, there was no nationally standardized test. And then at the beginning of the 20th century, a national test came on, the National Board of Medical Examiners, became the first national test to show across states that no matter what state you go to, you have an equal level of knowledge. It's not like law where you have to take a bar exam for each state. Now that examination, changed later to United States Medical Licensure Examination, is an objective test of knowledge and thinking that levels the playing field for people from all over the world. Because the United States actually has 25 to 30% more residency spots than it has graduates of its own medical schools. So consequently, we needed to measure across schools to assure competency and across the world to give an opportunity for residency directors like me to evaluate people's qualities from all over the world. 2/3 of medical schools in the United States have no grades in the first 2 years. How are you supposed to evaluate it when the first 2 years are pass-fail? That's why USMLE has become so important. So here's the thing that we're going to look at first. USMLE takes knowledge base and gives you some history, medical history. Oh, a man, woman of a particular age comes to a certain location like the emergency department or the office, and they have a particular chief complaint and a history of present illness, and maybe there is some physical exam, maybe there's no physical exam. For instance, in psychiatry, there's no physical exam findings. In cardiology, there's tons of physical exam findings. Pulmonary too. Then it says maybe there's some labs, maybe not some labs. Because there's some specialties like nephrology and hematology. What are you going to do? Palpate the BUN and palpate the hematocrit? So you have to have labs to be able to evaluate people. And in other specialties, again like psychiatry, what labs is there? Labs are only to exclude organic illness before we say, you got a mental health issue here, sir. So then we get basic questions. You can get asked, what is the most likely diagnosis? You can get asked which physical finding is most likely to be found in this patient. You can get asked what is the best initial test. You can get asked what is the most accurate test. You can be asked what is the best initial therapy, and of course what is the most common adverse effect of therapy. Now what I'm going to do with you in this short video is be able to give you a summary of what to do to prepare for the differences between step 1 USMLE, step 2, and step 3 of USMLE, and what are the differences between them. But the first thing to do is to study with the questions in your mind. Once you're studying with the questions in your mind, it means that you will be looking for those answers so that when you go to test day, and they give you a particular history or physical examination, and then you don't know what they're going to ask you. You don't know whether they're going to ask you what's the most likely diagnosis, what's the best initial test, what's the most accurate test. You don't know. But what you're going to do is you're going to go into your exam prepared for all of those questions. Let's give you an example. We'll give you an example of Wolff-Parkinson-White syndrome. Now, Wolff-Parkinson-White syndrome, you can say, what's the most likely diagnosis? Well, you have supraventricular tachycardia alternated with ventricular tachycardia. You can have supraventricular tachycardia that got worse with a calcium channel blocker or digoxin. That's how you answer what's the most likely diagnosis. Now, the other thing is there a particular physical exam finding? Yes, we talk about them, nobody can hear them. It's a loud S1. Why? Because it's premature closure of the mitral valve from premature excitation of the left ventricle. And it exists on board exams, and you need to know the mechanism for step 1. You need to know it's there for step 2, and you don't need to actually be able to hear it. And you might say, well, how do I know it's really there if I've never heard it? Is this cardiology or cardiotheology? I've never heard it, but I know it's there. Do you get asked what's the best initial test? Sure, and you might have to be able to recognize a delta wave, the delta wave. What is the most accurate test? Electrophysiology studies. What's the best initial therapy? Well, if you have SVT or ventricular tachycardia, procainamide or amiodarone. What is the most effective therapy? Well, the mafia says whack, the CIA says neutralize, and we say ablation. Now this, in what was less than 3 minutes, was taking a relatively sophisticated disease like Wolff-Parkinson-White syndrome and reduce it to 2 to 3 minutes. And this is how you're gonna prepare for USMLE, by putting all the questions in your mind. I have Wolff-Parkinson-White. If it shows me SVT alternated with VTAC, it's the only thing that does that. I have Wolff-Parkinson-White because it's SVT, where calcium blocker digoxin block down the normal conduction pathway. I have Wolff-Parkinson-White, allowed S1. I have Wolff-Parkinson-White. I have to recognize the delta wave. I have Wolff-Parkinson-White. The most accurate test is electrophysiology studies. I have Wolff-Parkinson-White. The best initial therapy, if you have SVT or VTAC, is procainamide. I have Wolff-Parkinson-White. The most effective long-term therapy is radiofrequency catheter ablation. Hit the tip of that catheter up to 95 degrees and burn that thing out. You now take this disease, you know all the answers to those questions, you put them in your intellectual pocket, and you're done. Now, there's only one extra thing to think about if you're adding on also questions for step 1 of USMLE, things such as what is the mechanism of how did this thing happen? Where did we get there? What is the etiology? Oh, worse with calcium channel blockers, worse with calcium channel blockers, and worse with digoxin. What is the mechanism? And the answer is forcing conduction down the aberrant conduction tract by blocking down the normal AV nodal tissue. What is the mechanism? Premature closure of the mitral valve, premature closure with pre-excitation of the left ventricle, slamming the door shut with a loud S1. What is the mechanism of the delta wave? Because normally the PR interval is the time it has to go from the SA node through to the end, past the end of the AV node. And if you're bypassing it, it means the ventricle has premature excitation and therefore contraction. Now you take that particular disease and you go, okay, I know that disease, we're all done, and now let's do that. Let's do that for everything. What is the most likely diagnosis? What is the best initial test? What is the best initial therapy? Which physical finding is most likely to be found in this patient? And you say a 68-year-old woman or a 68-year-old, maybe a man. It doesn't really matter because it's not the gender that matters. Oh, they come to the emergency department and they're acutely short of breath. They got acute shortness of breath and they've got rales to their apices. And they have shortness of breath and rales and edema, peripheral edema, rales and jugular venous distension. Step 1, not too much on the most likely diagnosis. Step 1, big on what is the mechanism. Step 2, very big on what is the most likely diagnosis. Step 3, they hand you the diagnosis and they say what to do about it. What to do. So here we're going to say how to prepare for all 3 steps with the same basic idea. What is the most likely diagnosis? Oh, that looks to be acute pulmonary edema, shortness of breath, RALS, JVD, jugular venous distension. Which is the most specific physical exam finding? What physical finding is most likely to be found in this patient? Well, lots of people can have edema. Lots of people can have RALS. Lots of people you can have jugular venous distension from pericardial tamponade. You can have jugular venous distension from constricted pericarditis from pulmonary edema. Fluid overload from not going to your dialysis. Shortness of breath is completely nonspecific. Life makes me short of breath. Sometimes why? So that's too nonspecific. But the physical finding, most specific, is the S3 gallop. It's the S3 gallop. Next, what is the best initial test? Well, you can say that you'll do a blood gas or a saturation to see decreased oxygen, but that doesn't really make that much of a difference, does it? I already know this person's short of breath. I already know that they can't breathe, they ain't gonna have low oxygen level. Oh, I can say, what is the chest x-ray? Oh, I can say, what is the echocardiogram? Or I can say, what is the EKG? Oh, now, question is, which of these tests, and now this is more of a step 2 question, which of these tests will make a difference, the greatest difference? Which of these tests will make the greatest difference in acute management? The most common wrong answer is usually an echocardiogram. Echocardiogram, very good. Echocardiogram is essential. Echocardiogram is indispensable to know, is this systolic or diastolic dysfunction? Is this preserved ejection fraction or reduced ejection fraction? Is it preserved ejection fraction or reduced ejection fraction? That is absolutely essential for long-term management. It's absolutely essential for long-term management because when you have heart failure with reduced ejection fraction, you're going to get an ACE inhibitor, an angiotensin receptor blocker. You're going to get a beta blocker that lowers mortality, a mineralocorticoid receptor antagonist that lowers mortality, and now SGLT2 inhibitors which lower mortality. But acutely, none of these make a difference. So that's a step 2-3 question. That's the step 2-3 question. The step 2-3 question is efficacy, benefit, and the greatest benefit. Well, there can be no greater benefit than saying what gives life. Because that's our way, isn't it, in medicine, what we're studying. You see, what we're studying is the way of life and freedom from pain and suffering. And those who see their studies in preparation for USMLE as a struggle to free the world of pain and suffering will have a greater benefit both for themselves and for the world. It means that you're going to learn what lowers mortality, which is going to make the world better. But it also means that you'll get a better score. You'll do better. But if your greatest concept of success is just the test and the grade, you can still get there. You can still perform well. But your trip, your journey, will be much more painful because it'll be lots of information, lots of data, lots of stuff to cram in your head. Oh my God, it's like a 1-gallon intellectual enema. Oh, this is a stretch, and I don't think I'm going to retain it. But if you say, what things will lower mortality in congestive heart failure? The most common reason to be admitted to the hospital in the United States of America. Bisto ACE, ARBs, something called ARBs combined with sacubitril, angiotensin receptor neprilysin inhibitors. Some of you might know it as Entresto, okay, valsartan and sacubitril, angiotensin receptor blocker, neprilysin inhibitor, co-equal at ACE or ARBs. What lowers mortality the most? Now, echocardiogram is indispensable, and these are very important answers, but they're not actually the answer to the question that we started out with. A person is in the emergency department with acute pulmonary edema. Which test makes the greatest difference in management? Again, a step 2, 3 question. What is the mechanism of the RALS, increased hydrostatic pressure in the capillary? What is the mechanism of the edema? Also hydrostatic pressure in the capillary, but in the case of RALS, it's the alveolar capillary. What is the mechanism of the S3 gallop? Rapid ventricular filling, nothing more than fillings. What is the mechanism of the S3 gallop? And the mitral valve opens, and the rapid ventricular filling is like a splash into the left ventricle. But these are the step 1 questions. Step 2 question. What's the most likely diagnosis? Doubt they'll ask you on this one. It's too easy. Which treatments will make the greatest difference in mortality and save life? That's probably what step 2 and 3. Those are the single 2 most important questions. Mineralocorticoid receptor antagonists. Some of you as known as spironolactone. I thought spironolactone was a potassium-sparing diuretic. Yes, spironolactone was invented as a potassium-sparing diuretic, but we rarely use it as a diuretic. We use it for its effect on inhibiting mineralocorticoids, for its effect on inhibiting aldosterone. So it's spironolactone and eplerenol. The SGLT2 inhibitors. Oh, canagliflozin, dapagliflozin, etugliflozin, dapagliflozin, canagliflozin, etugliflozin. It makes the sugar flows into your urine. It blocks the reabsorption at the proximal tubule. That's the step 1 question. How do the SGLT2 drugs work? They increase glucose flow and excretion into the urine. This urine is so sweet. Finally get the recommendation to eat the yellow snow. What is the mechanism? What has the greatest mortality benefit? Step 2 and 3. Beta blockers. What is the mechanism? They're beta blockers? No, but what's the mechanism? Oh, the mechanism of the beta blocker is that they decrease the heart rate. Yeah, how does that make you live longer? Funny you should ask, I'll tell you. When do coronary arteries fill? When you're relaxing or when you're exerting? It's kind of like asking you, when do you go out to eat? When you're on the toilet? No, I don't think so. When you're relaxing. And so the coronary arteries fill when the heart is slow. The coronary arteries fill when the heart is relaxed. The coronary arteries fill when you increase the amount of diastole. When you increase the amount of diastole, the coronary arteries fill. Also, beta blockers, are they antiarrhythmic or proarrhythmic? They're antiarrhythmic because they're anti-ischemic. So beta blockers, what is the mechanism? Step 1 question. What is the mechanism? Step 1 question. Slows your heart. And it decreases the oxygen consumption and increases the supply. Ooh, it's like switching to solar at the same time that you discover an oil well in your backyard. That's great. But what is the mechanism? Step 1. What is the best initial therapy? Well, if it was said that the person was in the office and had systolic dysfunction, reduced ejection fraction, what is the best initial therapy? Step 2 and 3. what to do, what to do, what to do, step 2 and 3, what to do, what to do, what to do. ACE, ARB, ARNI. Patient and a beta blocker 2. What to do, what to do, what to do. Mineralocorticoid antagonist. What to do, SGL2 drug. What lowers mortality? Step 2 and 3. Step 3 is big on saying, what is the prognosis? Now remember, step 1 is taken at the end of the second year of medical school. It's mostly basic sciences: anatomy, physiology, pharmacology, biochemistry, statistics, microbiology. Step 2 is taken at the beginning of the last year of medical school, or the end of third year, or beginning of the last year of medical school. It's all about testing to see whether you learn anything on your clinical rotations during third year. Step 3 is taken for US graduates after 1 year postgraduate, after internship, and for international graduates, they can take it. International graduates can take it. You can take it at any time after you've graduated medical school. And you don't particularly have to be certified in anything. You don't have to, okay? Because step 3 is the exam that gives you a license. You can't get a license to practice medicine in any state without step 3 of USMLE. So that's why step 3 is like this. I'm not going to ask you the mechanism. I don't care if you want to understand how it works. Do you know what works? Then we're happy. What is the most likely diagnosis? Which physical finding is most likely to be found in this patient? What is the mechanism of that physical finding? What is the most accurate test? What is the mechanism of that test? What is the most accurate test of an ejection fraction? What is the most accurate test of ejection fraction? And the most common wrong answer is echocardiogram, because the echocardiogram is not as accurate as the MUGA scan, the nuclear, not nuclear, nuclear ventriculogram, most accurate measure of ejection fraction. So let's go back to the original question. A 68-year-old woman comes to the emergency department. She's acutely short of breath, withdrawals, jugular venous distension, edema, and an S3 gallop. Which symptom is most specific? Is orthopnea. That's the most specific symptom. I lay down, I get short of breath. I sit up, I feel better. I lay down, I get short of breath. I sit up, and I feel better. Which of these questions will you be asked? Because if you look at it, we just said diagnosis, symptom, S3, mechanism, best initial therapy in the office, most accurate test of ejection fraction. If you look at all of this, I've just extracted 15 to 20 questions out of one single disease. Which of those questions are you going to be asked on your test? You don't know. But if you prepare and you know all of those questions, then you're going to do great. If you know 3 or 4 or 5, you might pass. If you know 10 or 12, you might do pretty good. If you know 15 or 20 for that disease, and this is a complicated disease, then that's where you're going to get super high scores and be in the 270s. But anybody who tells you that people who do better on that test is just test-taking games or gimmicks or tricks, or they're just better test takers. Oh, so you know just as much as the person, you got a 210 and they got a 270 and you know just as much? Oh yeah, it's just test-taking gimmicks. Well, no, it's not just critical thinking, because there can be no critical thinking without knowledge base. And people are going to live and die off how much you know. And if you do it the way I'm saying it, by saying, don't give me just the one question. And if you think that you're going to do well by just studying the same old step 2 question bank over and over, are you out of your mind? You think the people who are making and designing step 2 and 3 of USMLE, you think they don't know that you're all looking at one question bank over and over again? You think they're going to let the questions that are in the commercial question bank show up on the test? You cray-cray. That's not going to happen. But if you do it this way and say, well, of all these tests, and this is where we'll finish, of all these tests, the one that makes the acute difference is actually the EKG. Because if you have an arrhythmia, if you have VTAC, if you have an arrhythmia, or you have ischemia, you can do something different. If you have ischemia, you go to the cath lab. And if you have VTAC, what's the indications to shock VTAC? What's the indication for acute cardioversion? Chest pain. Oh man, you know, they're not perfusing the coronaries, chest pain. Shortness of breath, like this one. Oh, I'm not getting that blood out of my lungs. Hypotension, systolic less than 90. Better fix that right away. Shock that VTAC. Can't live at a systolic less than 90s. Confusion, I can't perfuse my brain. I'm feeling lightheaded. I'm going to pass out. So what are the indications for acute cardioversion when you have VTAC? Chest pain, shortness of breath, hypotension, confusion means you're not getting enough perfusion. Chest pain, shortness of breath, hypotension, confusion means you're not getting enough perfusion. So which test makes the greatest immediate difference? The EKG. So there's 20 questions. You throw in some ethics on the same disease, and you're done. But don't let anybody tell you, just do that one question bank. Because no question bank can have 25 questions and 20 questions on CHF and 25 questions just on coronary disease alone. Because your question bank would be thousands and thousands. We are like a flute with a single note tuned to 200 creeds and beliefs. Wish you well. Do it this way. You're going to get where you want to go, and you're going to feel much better. So saying goodbye from ZoorMed and wishing you well.